My name is Basil Safi. Next to me is Dr. Bandar Al-Dhafiri. We're going to moderate this first session of this, what seems to be an exciting program. I'm delighted and honored to moderate this session, and I would like to thank Dr. Shammari and his group for inviting me and to put such a great program. Our first speaker today is Professor Amr Gad. Professor Amr comes from the University of Cairo. He's an old friend of mine, and he probably one of the well-known vascular surgeons in the region. And if anybody is to speak on the prevalence in the Arab world, the prevalence of vascular disease in the Arab world, is probably Amr Gad. This morning, he said, just you have my CV. I said, if I'm gonna introduce you with your CV, it's gonna take me the whole 2 hours. So without further ado, Dr. Amr Gad is gonna talk to us about the prevalence of peripheral vascular disease in the Arab world. Amr.
Thank you, Mr. Chairman, for this nice introduction for me. And as well, I would like to thank Dr. Mohammed Al-Shammari for his kind invitation for me to participate in this excellent meeting, and as well to present this topic, which is a difficult one. He chose the title of the topic himself, and I tried to collect as much as I can from the data concerning the peripheral arterial disease, its epidemiology, and the clinical presentation in the Arab world. As we know, all the Arab world is a mix of countries that bind together with common themes and history. And also we know that the heavy burden of peripheral vascular disease is related to the high prevalence of diabetes, obesity, hypertension, dyslipidemia, smoking, and the sedentary lifestyle. One of the most important risk factors is obesity. Obesity is a risk factor for several health problems and is very high in the Arabs, especially in the female population. Also, hypertension, dyslipidemia are common in the Arab population. But strikingly enough, smoking is extremely prevalent in the Arabs, especially the Arab males. So, the combination of increased sedentary life nowadays, lack of well-developed public health, and also the suboptimal medical management in some countries of the Arab world, all of them contributed to the rapid rise of both prevalence of risk factors and also subsequent arterial disease in the Middle East and its complications. The WHO released many statistics concerning that, and this outlined a very challenging pathway for the region. There is 6 of the world's top 10 countries with diabetes in the Middle East. Also, the number of the population in the Arabic world is about 35 million, 9.2% of all the population of the Arab world. Worldwide, the figure is 8.3%, and these have diabetes. And this number is expected to double to 68 at year 2030. Also, the percentage of diabetic patients among the population will increase to 11.6. This table, quoted from the International Diabetes Federation, shows these 6 Arab countries with diabetes. We notice that most of these countries are in the east, in the Gulf area, and in addition to Egypt. And these are the names of these countries. You see, the incidence of diabetes is about 18 and more percent 2010, and would increase to more than 20% in 2030 in this Arab world. And we know that the international figure is 8.3 only. This map, also quoted from the International Diabetes Federation, show the burden of diabetes in this area, the Gulf areas and Saudi Arabia and Egypt. And also, the impaired glucose tolerance is high in 4 of the countries of the Gulf area as well. The percentage of undiagnosed cases of diabetes is still very high in Egypt and Saudi Arabia. In the Middle East, above 6%. While new cases in childhood of type 1 diabetes are very prevalent in Saudi Arabia in regard to the Arab world, about more than 24 cases every year per 100,000 child. As regards smoking, we said that it is very prevalent in the Arab world. We see in Jordan, it is ranked number 8 on the world with the male smoker. 61% of the people are smoking. Next comes the Tunisian males, about 60%, 11th rank. Omani males are the least in the Arab world, are smoking, who are 20% only. Jordanian, Lebanese, and Tunisian females as well smoke very much. As regards obesity, in 1996, Egypt was found to be have the highest average body mass index in the world. And it was found that 65% of the Arab males and 76% of females having obesity. Obesity, which means BMI is more than 30. This is called the New World Syndrome. The factors for that is the rapid urbanization occurred in the area with consequent sedentary lifestyle. And usually, this is written due to, after the discovery of oil in the region, increased caloric and fat intake. The culture of the Arab people, they are not used for exercise, and they have the appreciation of the female pulpness. This table shows the difference in the risk factors for diabetic foot. This shows that the obesity in the Arab world, and we see that the figures are also are much higher in Egypt. The highest one is 46.6% are obese in Egypt. Next come Palestine, then Qatar, and Saudi Arabia. All of them are in the Gulf area, in addition to Lebanon and Egypt. As regards the prevalence of the peripheral vascular disease itself, there was an article issued in Saudi Arabia in 2007, estimated that about 11.7% of the population have peripheral arterial disease. Most of them are asymptomatic. And they called for a nationwide screening program to detect this problem. Also in Egypt, in Suez Canal University hospitals, they found that 20% of the patients, of the diabetic patients attending the family medicine outpatient clinics in this hospital have peripheral arterial disease. While in Saudi Arabia, there was an article in 2012 showed that nearly 500,000 of the Middle East and North African citizens have some sort of amputation which is related to diabetes. And also he urged for national registries to be done in these countries. Here is the table which show the condition in the Arab world as regards risk factors of diabetic foot complications versus the Western world. We see that most of them are related to the social habits and the traditional medicine and surgery phobia in the illiterate old people. And also they usually walk with bare feet, and they wash 5 times their feet. This has had an advantage of inspection their foot regularly, but the problem that it may be kept wet, especially in the interdigital spaces which harbor the fungal infection which predisposes to diabetic foot problems. Also, the healthcare providers have low awareness of the magnitude of the problem of diabetic foot, and the rehabilitation is still suboptimal. The clinical presentation of peripheral arterial disease, all of us, I think, note. I will focus only about some important data. We know that atherosclerosis is the main cause of peripheral arterial disease in the world. And due to the presence of risk factors mentioned above, usually these risk factors are associated with endothelial dysfunction of the arterial system. In Middle East, we are usually faced with inflammatory arterial disease, which are Berger disease, Behçet's disease, non-specific arthritis, and the Takayasu arthritis as well. This picture is an angiogram for Takayasu arthritis. The patient of atherosclerosis usually around the age of 60 is male mostly, and usually is a smoker, as we said. A big percentage of them are hypertensive, dyslipidemic, and are diabetics as well, and we see this figure is very high, and we'll show it later on. As regards Berger's disease, it is known that it is common in the Middle East and Asians. It is rare. It occurs usually in young adults, males, 90% males, heavy smokers, and usually in the lower limbs and affecting small and medium-sized arteries. As regards the term of non-specific arthritis, we recognize that in Egypt since many years. Our professor Hammam in Charing Cross 2003 mentioned that in the last century, in the 60s, when he started and Egypt started reconstructive arterial surgery, they found inflammatory non-atherosclerotic disease, and it was non-Berger, non-Behçet. And this is a picture usually of the disease. Very healthy vessels and affecting any artery like the popliteal artery, which is not common for atherosclerosis because the SFA is very healthy. And these patients, usually young adults as well, and maybe females. The presentation of the peripheral arterial disease, either intermittent claudication, as we know, but more commonly we face critical limb ischemia. Critical limb ischemia is characterized by the presence of wrist pain for more than 2 weeks with analgesics. Ankle resting pressure is less than 50 and toe pressure less than 30. The presence of gangrene and the presence of ulcer also is common. In our study in Cairo University, we had some data I would like to show it to you, that in the infrainguinal segments treated by either PTA or bypass surgery, we find that diabetics are 63% of the people with femoropopliteal segment disease. And most of them, 55%, falls in class D, task class D. As the people with infrapopliteal disease, diabetics show the percentage of 91.2%, and also a big percentage fall in task D and C. Here is the clinical presentation with task D aortoiliac disease. We face these cases very common with juxtarenal occlusion, and we do the routine conventional aortobifemoral bypass, which is a gold standard for such cases of task D, while task A, B, and maybe C, we treat them by angioplasty. Also, we faced many cases with very long occlusions, multi-level disease, and we were obliged many years to perform femorodistal, like dorsalis space bypass. Nowadays, we can solve these problems by endovascular techniques like this case. This is an infrapopliteal disease, total occlusion, nearly total occlusion of the anterior tibial. And posterior tibial peroneal is weak. After dilatation with long balloons, we could save a patient with extensive infection, diabetic ischemic foot, as well as these other cases of infrapopliteal reconstruction by PTA. We found in our study in Cairo University that the multi-level occlusion in the same patient occurs about 20% of cases. And also, bad runoff is present in 50% of cases with single vessel runoff only. We can conclude from this that diabetes, obesity, and smoking are more prevalent in the Arab world, especially in Egypt and Gulf countries. And PEDs is slightly more common according to the available data up till now. Approximately 52 to 91% of peripheral arterial disease are diabetics. The lowest figure is in aortoiliac disease and the highest figure in the infrapopliteal disease. Multi-level disease is common, 20%, as we said. Single run-off vessel only in 50% of cases. There is high prevalence of task D group. Diabetic foot infection is common in the Arabs due to the reasons mentioned above. And then inflammatory arterial disease like Behçet, Berger, non-specific arthritis are prevalent in the Middle East. So we call also for nationwide screening programs and the registry in the Arab world in each country to urge the health authorities for better screening of the cases with peripheral arterial disease and the risk factors for proper management and trying to cure the patients with the complications of peripheral vascular disease. Thank you, Mr. Chairman.